while we're waiting, we are going to do some box breathing, also known as square breathing, four-part breathing. So as we do this for the next 3 minutes, as people are joining, um, really quickly, I'm going to pause. Nicole or Sarita, will you allow people in when they come in while I'm doing this? Thank you. So three-part breathe or four-part breathing, square breathing. We're going to breathe in for a few seconds, hold, breathe out, and then hold. Okay, so I'm going to guide you through this, but feel free to practice with us. Just take in a big deep breath. Hold. Exhale. Inhale. Hold. Exhale. Hold. 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 Let's do one more round. Inhale. Hold. Exhale. Hold. So we know that box breathing and four-part breathing, and if you were counting, it's usually 4 seconds on each side. So that's where the four-part breathing comes in. So it's inhale, hold, exhale, hold for 4 seconds each. And it has been proven to help us calm our brain, to focus. So if we have time to do that daily, it will let us practice calming ourselves. This particular video has been We've been borrowing that from the University of Alabama at Birmingham, one of our PPN hub sites. But if you Google 4-part breathing or box breathing, there are many videos out there to help guide you through this as well. And with that, I will hand it over to Liz to get us started. Thanks, everybody.
Awesome. Thank you, Julie, for leading us through that. I know when I was reviewing the slides earlier today, I was actually looking forward to that few minutes that I knew I would actually just get to sit in silence. So I think it's important for us to remember that nothing changes if nothing changes, and we have the power to build some intentionality around the way that we conduct business. Obviously, this field, disaster management, disaster response, can be a stressful one. We are also living in a very stressful environment and a stressful world. And I just think it's important for us to bring this when we can to our own lives, families and friends and colleagues. So with that, also, I think just congratulations. This is the last focus area session for the Surge focus area. We have made it several months worth of content, and truly from the team that's been putting this together, we're also grateful for you all to be participating and engaging with us. It's really helped direct our sessions, and it's crazy to be kind of at the end for us, but we're happy to see where the next phase of this work goes, which I know Julie will talk about briefly at the end. So with that, next slide, and we'll get into some of our normal business as usual, our acknowledgments and disclaimer. Just a reminder that we're supported in part by Health and Human Services, 0% financed with non-governmental sources, and the content presented here is that of the authors and does not represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. Next slide. Our learner notification for claiming CEs, this will be provided. I'm not going to read it out, but the credits available for physicians and other various continuing education relevant information there. You will get follow up on that. Next slide. Again, just normal announcements. We're happy you're here. Session is being recorded. The recording and the slides will be posted online. If you have questions and answers, please put them in the chat box, or you can raise your hand, and we will try to get to those as we move through. CE available for nurses, social workers, physicians, and MOC Part 4 available for physicians. The current priorities, the Drill 1 data collection survey, Drill number 2, and Drill 2 data collection survey. Next slide. So just a real quick look at our agenda. We did our box breathing. I'm doing the intro. I'm going to tell you guys a little bit about a resource that we've been putting together on the side as part of our work as the PPN Surge domain, which is kind of another channel that this team works on. And then we will also have sessions intentionally designed to be able to bring you guys at least a little bit of the information that was presented in the other focus areas. Both Nicole and Sarita, who are our speakers, help to lead those other focus areas that you may or may not have been able to participate in if your hospital was wholly selected Surge. So obviously it's not going to be an entire download of everything that they've learned during that the quality collaborative in its length, but really being able to hone in on the Surge strategies related to both decon and reunification. We will have some times carved out for some discussion. I'm not sure if we'll do breakouts, probably just some group discussion. And then Julie will close us out with some just collaborative information and next steps. And next slide. The objectives are today to identify the relationships between surge capacity planning and other areas of disaster planning, including decon and family reunification, to discuss some strategies, lessons learned, and barriers associated with using tabletop exercises and drills to enhance preparedness and responses capabilities during surge events, and to define concrete next steps to sustain surge capacity planning and collaboration beyond the DRC, including identifying responsible roles, needed resources, leadership engagement strategies, and opportunities for continued community collaboration. Next slide. Okay, so just real briefly before we jump into our topics, prior to the launch of the DRC, the Surge domain of the Pediatric Pandemic Network went on a somewhat lengthy, not lengthy, but we've been working on this for several years intentionally to provide a surge resource that could be applicable to all hospitals. Now, we recognize that that's a challenging order, right? Because there are many different types of hospitals when you're talking about pediatric considerations. But the goal of this resource was to be short and sweet. And I think we've kept it to around 30 pages. So I feel like for handbooks, that's pretty short. 1 to 2 pages on each of these sections, really highlighting key resources and considerations as it relates to Surge. We've followed the patient path, including some foundational concepts like space, staff, and supplies, HICS and communication, engaging external partners, things such as that. But really kind of following that patient track through pediatric triage, all the way through family reunification, and including some mental and behavioral health resources here. All of these resources are linked throughout, so obviously each of these topics can be dove into very deeply, but we wanted to be able to provide you all who've been with us throughout the collaborative a way to kind of have that resource that can give you kind of the things that we consider and the subject matter experts that participated in this project consider to be the things that all hospitals should be able to do when it comes to pediatrics. So we are happy to share that with you after the fact, and also welcome any feedback on if this is helpful or if there's something else that you may need as you continue to go down this journey of refining and reviewing your surge plans and making them, improving them. Next slide. And with that, I'm going to go ahead and turn it over to Dr. Nicole Davis, who's going to talk about decon.
Awesome. Thank you guys for having me. Like Liz said, I am Nicole Davis. I'm at Texas Children's Hospital. I am a pediatric emergency medicine physician and did my fellowship there and then stayed on as faculty 6 or 7 years ago. And then I also am the associate director for our pediatric disaster preparedness for our division. And so I've been involved in the DRC. Our hospital is also participating, but we are in a different focus group. So this is my first time to the Surge focus group. So thank you. Next slide. So we're going to talk a little bit about decontamination today, and we're not going to go over kind of all the ins and outs of how to decon a patient. There are lots of resources out there for that, but we're going to talk about kind of the considerations that you need to make in order to decon a pediatric patient and their family. And so the goal of decontamination is simply just to ensure that a toxic substance is no longer in direct contact with the patient. This not only prevents the further absorption for the patient, but also then decreases the possibility of transfer of that substance to a healthcare worker. And so what we kind of always say is that you're trying to protect the house. You're trying to make sure that as the patient comes in, not only are they safe, but you're getting all the substances off of them to ensure that your healthcare workers and your areas and all of the future patients and current patients are also safe and not also involved in this contamination. These toxic substances can be chemical, but they also can be biological or radiological. Next slide. So as we know, children are not simply just little adults. Their physiology and their anatomy make them actually different, not only in the procedures we need for decontamination, but also in their susceptibility to the different agents. So they are at risk of greater exposure to toxic substances, specifically things like biologic and chemical exposures. And this is because they have increased permeability of their skin, especially when they're young, so infants and toddlers. And then because of the rate at which they grow, we know toddlers have larger heads than they do bodies, and that kind of normalizes as they get older. They have a larger skin surface to body mass ratio. And so they actually just have more surface area for absorption. They do have a higher respiratory rate, meaning that anything that's been aerosolized, they increase their intake or susceptibility to those substances. And some toxins, based on their molecular weight, are in higher concentration closer to the ground. And of course, because of a child's height, they are closer to the ground as well. They also have increased susceptibility because they have less mature immune systems. And depending on how old they are or the family's preference, they could have partial or incomplete vaccination status that put them at risk for biological attacks or exposures. And then they are at greater risk for some of the complications, specifically looking at the actual decon process, the symptoms of the exposure, and kind of the long-term effects of certain exposures. So if you look at a radiologic exposure, acute radiation sickness is due to damage to the actual cells that are dividing. And because children have rapidly dividing cells, not only internally, so with their solid organs, but also as they're growing, so their skin, their respiratory tract, even in their hair, they are at increased risk of developing acute radiation sickness. And then because they are expected to live longer, given how old they are at the time of exposure, if they're only a toddler or a young child, their risk of long-term malignancy is also greater, not just because of their rapidly dividing cells, but also just because they have a longer life expectancy ahead of them. Children do not compensate as well when it comes to hypovolemic shock. So any sort of exposure that increases vomiting and diarrhea, and therefore all of their GI losses, they're at increased risk of leading to actual shock and the inability to compensate. And they also, again, because their surface area to body mass ratio and some internal regulation factors, they are more likely to become hypothermic and they're unable to regulate their temperature. And so all of these things are important to understand when we then go ahead and talk about decontamination, because this is why this is important to think of the kids as not just little adults and kind of need to specifically be thought of when you're doing your decon planning. Next slide. So I do want to talk about the difference of wet decon versus dry decon. Most of the time when someone says decontamination, what they're referring to is wet decontamination. We're thinking of the big tents that are set up outside and the showers and all of those things. But in reality, we believe that 99% of this is chemical specific to contamination, can be eliminated by carefully removing clothes and wiping the child's skin with a paper towel or dry wipe. But there are some limitations to dry decontamination. So this is less effective in a patient's hair. So if they have long hair or even just really thick hair, if the hair is in a hairstyle that is difficult to actually assess, or if it's an oily substance, it can be very difficult to use dry decon in a patient's hair. It's also less effective for anything that's in a particulate form. So this means things like asbestos, heavy metal dust, potassium cyanide, or any resins are very difficult to actually remove with dry decontamination. And the same goes into place for the highly viscous or kind of sticky or adhesive materials. So anything like thick lubricants, mechanical lubricants, any glue, cement, is very difficult to be successful with dry decontamination. And so this is something to consider when there is a surge and you're trying to triage who can come in, who's medically stable, who's the sickest, and what your capacity for wet decon looks like. Because if you have to do a risk analysis and do some balancing, remembering that 99% of that chemical contamination can be removed simply by wiping the skin and removing the clothes is important when you're kind of making those next step decisions for a decon surge. Next slide. And so your actual decon procedures, specifically with your wet decon, do need to be augmented for children. And so speaking on arrival, whatever your triage method may be, if you're using a pediatric specific decon, or if you're applying a pediatric specific triage, or if you're applying an adult triage method to your pediatric patients, once you get them triaged, the children within each triage category should enter the decon lane first. So if you have 20 red patients and 5 of them are kids, those 5 red patients should go first. Now, considering that you do want to preserve the family units, and so if you have a whole family and the child is a green, but the adult is a red, you would still bring that child up with that red parent and bring them through the decon line together, simply because you're trying to preserve the family units. And then, of course, you need a process in place for ensuring that you are tracking these patients as they're going through and their belongings. And Dr. Srita Chung will actually speak about this here in just a few minutes. Carefully, we need to make sure that we're not carrying children through a wet decon line. We say children are slippery when they're wet, and they don't love being there. And so the likelihood is that you will likely drop a child. If a child can't walk themselves through or do decon on their own, then consider them non-ambulatory. And so you need a way to get those children through, and different than adult non-ambulatory children, or sorry, adult non-ambulatory patients, most of the time an adult that's non-ambulatory is also typically not going to be combative or try to get off the lane or out of the lane because they are non-ambulatory. A child that we're considering non-ambulatory, that may not be the case. While a toddler may not be able to go through the lanes themselves, that does not mean they can try to escape the lanes, and they likely will. And so we need to not carry them through, but also consider them non-ambulatory. And remember that they're kids and they're going to be likely hesitant or fearful both of taking their clothes off in front of a bunch of strangers or getting in and out of the showers because these are scary. The equipment that we're all wearing during the decon process is very scary, considering PAPRs and kind of what you're wearing can be hard. And so making sure that you consider that and have ways in place to keep our kids safe throughout the decon process is important. Next slide. So with your equipment considerations, in a wet decon situation, you want low pressure, so that's defined as less than or equal to 60 psi, but high volume systems. And handheld systems are better. So your showers where the shower head is really far away are difficult for kids. And so handheld means that you can kind of allow the water close with a wand and really specifically get the areas that the child wants to or the child needs to have water over at that time. You can simply use for most contaminants, just use water. But also if you need to, you can add a mild soap. Again, considering irritation to their eyes and that a child that doesn't even want to get in the shower at home is likely going to be hesitant to this process. The water temperature needs to be about 98 to 110 degrees Fahrenheit. And this also means that you need to have a way to monitor the temperature throughout the decontamination process. So not all decon systems and all showers have a temperature gauge. But if you don't, you need to look at this and find a way to be able to monitor the temperature because again, children at increased risk of becoming hypothermic, and it actually happens very, very quickly, specifically if your environmental temperature is cold. And so since we can't pick when a decon event is going to happen and certain areas of the country are very cold, this is definitely a priority for your system. Also having prompt access to sheets, blankets, and even Mylar blankets to keep the Mylar covers to keep them warm after the decon process. And then again, because we don't carry children through, considering they are non-ambulatory, but maybe not super ill or altered, thinking about ways you can get the children through the decon line. This picture is actually from Illinois EMSC, but I know many decon and hospital systems use this same process, and ultimately it's just a plastic laundry basket. And this way toddlers can sit down in it. They can be lifted up and put on the roller system and kind of rolled through the decon line. It is important that if you're using something like this, that it has adequate drainage. And so a lot of times you actually do need to modify this and drill holes into the bottom of the laundry basket, because even in this picture you see here, there's probably 3 to 4 inches of standing water in the bottom of that laundry basket if you don't have proper drainage, and children can drown, or then they're sitting in the water that should be the runoff water as well. They do have bassinets that are meant for this process that are mesh, but they can be kind of expensive. And so if your system is looking for something that is pediatric specific, but a little bit more affordable, you can modify laundry baskets to do that. Next slide, please. And that is all I have. I wanted to keep this short and to the point and really focused on just the things that you need to look at that within your own policies and plans as you've gone through this surge focus group, and make sure that you're thinking about children and the ways you need to augment your policies and procedures. So thank you so much. My email's on the screen if you have any questions. And I think we have a few minutes, Julie or Liz, we have a few minutes here for questions, if there's any, before we move to Dr. Sarita Chung.
Absolutely.
So everybody can unmute. So if somebody has a question, you can either raise your hand, type it in the chat, or come off mute.
All right. Well, if no questions, or if you're just thinking of them, we can move on to Dr. Chung. And if you have questions, feel free to just add them in the chat and we can always address them later as well. Go ahead, Sarita.
Hi, everybody. Thank you so much for joining. I'm really excited that you're here. I'm Sarita Chung. I'm a pediatric emergency medicine at Boston Children's Hospital. I am also the chair of the Council on Children Disasters with the American Academy of Pediatrics. And with some colleagues here, Anna Lynn and others, help lead the Family Unification PPN DRC. So we're going to try to share some highlights from our DRC in this group, and please let us know if you have any questions at all. And I will just say, Julie and Liz, I suck at box breathing. I keep so it was really good for me to practice, but I can't hold, and I inhale and exhale at the wrong time. So I continually need to have practice for that. So anyway, next slide. So, similar to how Nicole was thinking about challenges of children during decontamination, similarly as pediatric healthcare providers, you're aware of the challenges regarding reunification. As far as developmentally, they may not be able to self-identify. They may be afraid of you and run away from you. They don't carry identifying items like a license, especially the younger kids. And while they may self-identify, they may not know their parents' info. So if you ask a 2-year-old who mommy is, they'll say, of course, mommy, so they may not know their names of their parents. With regards to the hospital, there are challenges with keeping the children safe and protecting the children and making sure that you know where the children are at all time. And so what that will require is an escalation of staffing. And then and this was really one of the main concerns in our own section of family unification, our DRC PPN, is legal, what is legally allowed, how can we confirm guardianship, what information can be shared. And so I think there are legal concerns that we need to think about. And there actually was a study that showed delayed reunification did increase mortality and hospital costs. So really trying to get children reunified as soon as possible is a main priority after disasters. Next slide. And so as hospitals or being part of hospitals, you're always going to be involved in a disaster, especially one that causes trauma. And so these are just some headlines after the Boston Marathon. Sharing the challenges of identifying patients after the marathon bombing, and really the number of calls that were logged in just a 24-hour period where people were looking for their loved ones. So it really does take a system approach, but you also need to make sure that your hospital has plans for reunification. And so nationwide, it's about 50% of hospitals have a hospital written reunification plan. It is now a joint commission requirement, but still people are not comfortable with their plans, and their plan may just be one page, like we have a plan, and that checks the box for joint commission. There was a nice study that showed that predictors of having a hospital written reunification plan, including having a pediatrician on your hospital disaster committee, conducting a family reunification drill, or implementing the 2018 AAP and MGH healthcare reunification planning tool. Next slide. So who do they trust? So this was another study that was done looking at who parents trust, and this was a study done in Massachusetts and Missouri. And then next click, Julie. It went out, but actually hospitals scored much higher. So hospitals scored much higher than national organizations, much higher than local government. And it's very interesting that your universities, so some of your hospitals are associated with universities, and you would think that would provide more trust, but actually it was much even lower. And then out-of-state government was the lowest. Next slide. And so I think I'm going to go by, this is an animated site, so I apologize to Julie for doing this to her. But I just want to kind of relay some expectations that you need to really incorporate into your plan. And so, one thing is that, if your expectation is that families will obey, evacuation instructions. I always ask this question during presentations, and I say, you know, your the school is one way, and the school is on the east side of town, and then but there has been a disaster there, and you're being told by local officials not to go to the east side of town. Who's going to obey your instructions? And next click, Julie. About, they looked and they said 63% families would disregard evacuation instructions. So if you tell people not to come to your hospital for family reunification, they're going to come anyway. So they're not going to obey that. They're just really panicked and in search for their children. And usually when I ask this in public forums, it's usually about 100% that nobody's going to, obey any kind of instructions. One other expectation is families expect all hospitals to have a plan to reunite your families. Next click, Julie. And in the PEDS Ready data, next click. Still to this day, only 47% of emergency departments report having a disaster plan that addresses children. So we know that there's a way to go as far as implementing that plan. And the most important thing is when the families get there, they expect immediate identification and reunification of all survivors. And so, next click. You won't have that information. So you have to make sure in your planning and your policies, you already have set communication that describes the process and how you may not have that information at that time, and how you will be able to contact families when you do have that information. Next slide. And then when we think about it from the hospital expectations, these are some that I've heard over the years. Sure, I should think about family reunification, but my hospital is not really going to be affected. We're not a trauma center. My community has a family reunification plan, so I don't need to think about it for the hospital setting. And then my hospital already has a plan. And so for those, I would say, next click. So after a disaster, now we know, and the research shows that most people will go to their closest hospital. Next click. And so, and just thinking about it, even if you're at a place where if you're traveling or on vacation, or people are vacationing in your city, they may not know which one is a trauma center, and or not know which hospital would be able to take care of kids. And I did this experiment, and it would be interesting if it's replicated. It can be replicated, but I'm at Boston Children's Hospital. I live a mile away, and I asked Siri, where is the nearest hospital for trauma, for children, and or for trauma? And they actually led me to a hospital that is an hour away from me, saying that the closest hospital for pediatric trauma is UMass, which is in the middle of the state, and I'm on the east side. So the information, or where you get your information, or where the community is getting their information, may be incorrect, and they may send you to a hospital that you weren't expecting to have any kids. For your community to have a family reunification plan, next click. Families usually head to hospitals first. So you really need to think about, even though if there is a plan, you will still get crowds. And so I think you need to make sure that you have a plan in place to make sure where you will send these people that will not interfere in the care of all the disaster victims. Next click. And the community family assistance centers will take time to set up. So it will at least take 8 to 12 hours to set up. So they will come to you first. Next click. And if you already have a plan, I would just say that's great, but make your spaces bigger. You really want to drill to failure. We had the Annunciation School shooting community come talk to us, and what was reflected, and what's been reflected in previous disasters, is that there's probably 8 to 10 family members, friends per child that will come to a hospital. And so in looking at it, and then you really need to think about what spaces you have in your hospital that you can accommodate that space. And that's what was echoed in the Hennepin Health Center, is that we just didn't realize how many people were going to be coming looking for their loved ones, especially when it pertains to children. Next slide. And so when we think about hospital space planning, we think about for these distinctive areas to kind of think about where you need to keep children and their families, and then how we can reunify. So we have the pediatric safe area, and so those are children that have been medically evaluated and medically cleared and are unaccompanied, and this can be transferred from your emergency room to a safer area, an area where whether you have social work or child life specialists or other credentialed personnel who can help take care of the children once they've been medically cleared. We have a family assistance center or a hospital reception site. Note, I don't call it a family reunification center because that gives the expectation that every family is going to be reunited. And so I think we've really tried to change that nomenclature to say this is a family assistance center who will help try to reunite you with your loved ones. The next area is a family reunification area. And so this is important so that, the children may be in the pediatric safe area, your family may be in the family assistance center. You want to make sure that there's a separate area where you can actually reunite the family. You don't want the parents to go to the pediatric safe area to get the child. You don't want a child to go into a family assistance center. So should be a separate area. And you want to be, I want to say, savvy in the sense that there will be some patients that are deceased. And so you want to make sure in your pathway that it's not that all the children who are alive, the parents are going to the right out of the family assistance center, and all the children who've passed away, all the parents are going to the left. Parents pick up on that really quickly, and so you want to track out your paths to make sure that you are able to reunite as soon as possible, but also not share that kind of way of all the deceased people went this way, and all the people that are not deceased went the other way. And then a media area, there you will get media to come in and talk, and they'll try to come into your emergency room. And so really being thoughtful and setting up a media area so that they're away from, the family assistance center, the family unification area, the pediatric safe area. They're just in their separate, I want to say, corner, so that they don't interfere with pediatric care, patient care, and the process. And for each one, the RAPM actually has a really nice incident command job tracking sheet. So the RAPM has a community reunification or hospital reunification site handout, and they have listed, incident command and leader for each area and tracking area. And just to say that the Family Assistance Center, this is an example. We've done different simulations. Definitely would try to avoid having like a classroom or just one room to do as your family assistance center. If you have a room almost like a waiting room, or that has can have ability to talk in small groups, or to have different rooms, different smaller rooms off the side for privacy, I think that's helpful, because I think if one person gets very anxious in this room, they'll incite the whole crowd, and everybody will be anxious. So you need a way to figure out a way to peel off those people that may need extra support. Next slide. And so this is your pediatric safe area. This is a controlled, supervised space where medically cleared children can wait safely and securely. There's a process to register and track any accompanied minors. They, during that time, you should think about a way, how are you going to gather all the data and from each child, or what the child can offer. Can they tell you their name? Can they tell you their parent's name? Is there all the information that that child can share? And then it's nice to have a clear visualization of, like, these are the unaccompanied children. And so whether you use colored purple bands or bands to share that they're unaccompanied. You also want to have this area close to a restroom, because when one person wants to go to the bathroom, everybody wants to go to the bathroom. So just making sure that in your plans that your pediatric safe area is able to be secure, close to the bathrooms, away from the emergency room, and away from your patient assistance center. And I think one thing, once you develop your plans, as we said, definitely drill it. We've drilled this a few times, and what we've noted is that the voice in this room is so loud that you actually, you really are not able to keep toddlers and younger children in this room. It just really upsets them. So we ended up in our drill, we had families trust us with their children, and we had like a 6-month-old and a 9-month-old. And every time they came in, or they were carried into this room, they just started crying. And so we realized that we needed to have a separate space for the younger kids. And then now we also realized we probably need a more quiet space for those who have sensory integration issues. Next slide. So this, I think, is a really cool, that was done by Michelle Pintier at St. Louis Children's, way to think about developing your reunification plan at your hospital using QI principles. And so this is their driver diagram, and their aim was the creation of family reunification plan for a pediatric center to start within 4 hours. And 4 hours is really ambitious, actually. I've spoken to other hospitals who would not be able to do that, but that was their goal. Their primary drivers were staff, space, stuff, and systems, and you can see their secondary drivers and then specific ideas for intervention. And this is how they were able to craft their plan. Next slide. And then this is how they further, if they created a fishbone, and how to further divide up their plan. So who are the people that they're going to need to use? And this includes people working with parents. These are people with children and security. What spaces have we identified? So, where are the parents going to go? Where's the reunification area? If we needed sleeping areas, where would that be? What processes do we need to have? And then what equipment do you need to have? And they actually have process mappings for the unaccompanied child and also the parent looking for their child. So I think it's just a kind of a neat way to look at this. Next slide. And so then we think about family vetting forms, and just to think about in your hospital, how do you want to try to get as much information from the children and then as much information as the parents, and try to match them. This is just an example of a vetting form and that we have used in our hospital for my children that have been in disaster drills. And so really, the name of the child, the age. We actually now probably think hair color and eye color is probably less helpful. There's been studies shown that the parents are not actually really good at doing eye color and hair color, which is another topic of discussion, but they're just not. And then clothing is a very interesting one, where like maybe the younger kids, if you've dressed them, you would remember, but for the older kids who dress themselves or who decide that they wear, like my son wears one outfit to go to school, but he immediately wants to wear shorts and takes off his clothes, his sweater and his long pants that I make him wear during the winter. His clothing would be totally different. So those kind of characteristics I would probably say are less useful. What is more useful is names, ages, and actually, do you have a pet? That was like one of the top questions that people as young as 3 can answer, and the name of their pet. So that was a very, very interesting finding when we did our unification drills. But it's important to have this just so that you can correlate the information. Next slide. And so this, I just want to share as the Pediatric Surge is running, we have also ran a parallel PPN DRC family unification series. And so this is just to highlight, this is, you can see all the previous sessions that we have done. And what has been really nice is Anna Lynn, who's on this slide, has created a Padlet, or I would like to call it a cheat sheet of like what the sessions were and what were the key takeaway points and what were some relevant articles. And so if you go to the collaborative side and look at the past reunification sessions, there's a Padlet that can guide you. And if there's more information that you would like, then you feel free to download any of our sessions or recordings. But we similarly have talked about like lessons learned from real events, space, staff, stuff, supplies, really thinking about how to building your effective team, what kind of communication or information sharing do you need. Medical legal issues was really great, and Marie Lozana, who's on this call, really helped out and really talking through the medical legal issues and reunification. So I just wanted to point that out, and feel free to check it out. Next slide. And that's it. Thank you much. If you have any questions, please let us know. Actually, as we're waiting for questions, Anna, do you want to? I'm going to put Anna on the spot just because she really is the lead. I'm just supporting her in this PPN DRC reunification. If there's anything else you wanted to add, Anna, please come off mute.
I think, Sarita, you've done a beautiful job, and thank you, Nicole, also for speaking so eloquently about decon. I think the work that a lot of our participants in DRC has embarked upon, and the work that you guys have all embarked upon, has been so important for supporting our children in the worst of times. So really, every session and every focus area has been uniquely designed to help facilitate improving these types of plans. And so thank you all for joining. If you haven't thought about some of these other plans, I think the one that we didn't include as a showcase in this one is evacuation. There are so many resources on the DRC website, and so thank you for participating in Surge, and hopefully you've participated in some of these others, and hoping that this community of learning will continue and persist beyond the DRC in and of itself, which I'm sure people will be talking about. Thank you.
Thank you. I'm going to turn it back to Julie and Liz. Are there any questions?
Awesome, thanks. I don't see any. We do have a comment from Marie that I think it's important to note that this is an area that even focused children's hospitals struggle with perfecting this process. It's not something that's easy to, I think, simulate and drill. It requires some planning and some thought. And I think your point, Sarita, about drilling to failure is a really nice way of thinking about that. I sometimes think that we take our drills and those failures and we let them kind of get us down, but I think that's the whole point, is identifying those failures and letting them propel us into better plans. So appreciate that context. Julie, do you want to kind of lead us through a few minutes of open discussion? I don't know how we're doing on time, but I know you have some follow-up remarks.
Absolutely. We've got time. So again, everybody should be able to come off mute. I'm going to go to the next slide. So again, last focus area session, we've made it through a year and a half of DRC. Hopefully you feel like you've made progress, you've learned things, you've been able to implement some things. So we thought maybe let's talk about what's next. Now, my PPN update and next steps slides have little things that we are going to offer you. But what do you have planned in your hospital, in your facility? What if you have thought about it, and if not, let's start thinking about it. What are your next steps? How are you going to sustain the work that you have put in? So I'm going to put these questions in the chat, but I'm going to stop sharing so that we're in an open room and kind of face to face. So feel free to come off camera, but if you're not comfortable with it, don't worry about it. But again, you have the audio button on your bottom left toolbar that you can come off mute if you have a question. And Marie, I see you have a question, so I'll feel free to go.
I more have a comment and maybe a question. You'll see my colleague here at University of Michigan, Stu Braden, and I doing the full disclosure report out about our very complicated full health system, full community exercise that we did, and the massive amount of lessons learned. And reunification was a very big learning area. We are a full service quaternary care children's hospital, and yet we have a lot of resources to do this. But it's the process, it's the having the right rooms, the right process, the right folks, the right staff. I think we assume if we're a particular type of hospital that somehow it'll just get done because we have the expertise. Sarita's guidance around the space, the staff, the stuff, the process. We are still working on that. So I feel like this will never be done. We'll just be iterating and iterating. So you'll see us very much disclose our work to be better in these spaces. We're great at a lot of things, but we need to be better in certain spaces. So I think being an all call, all learn, all teach forum and keeping that up is going to be helpful. So I just thank Sarita and Nicole for their work in this space, because every time you go and do your after action report, no matter whether it's a mini drill or a community-wide functional true exercise that you plan for many months, there's so much to do. And I think we got to not be depressed by that, but be energized by it and use the opportunity for improvement. So I appreciate it.
I totally agree, Maria. I don't think anybody has the solution. I mean, there's some really great plans out there. I would have to say at our hospital, there's been a lot of turnover. And so while the plan gets reviewed annually, we haven't had a deep dive. Like, we haven't had 50 children come in to try to test our plan. And when we did that, and that was part of a grant, we realized we lost children, right? Like, we had an intake process where, they were right in the room. They had to go to this one space first to get their picture taken, and then they could go to the rest of the room. And one kid didn't want to wait in line, and so they actually skipped the line and nobody noticed. And then when the parent was trying to look for the kid, we realized we didn't have their kid in our database because they had missed line. And so we gave that parent unnecessary hypertension, because then they were panicked. They were like, where is our kid? You had our kid. And I was like, the kid has to be in the room, right? But so it really just helps test our process. To really, I think using a drill, as said in the objectives, really helps focus and helps us just look at each of the processes. And I wouldn't go big, right? I would do small things. I would identify your pediatrics safe area first, see what is needed, what are the process you needed at first, or maybe even the family assistance center. That's a larger beast, and just really what do you have already prepared at your hospital. So just I would think about it in small ways as you conquer this.
Rita, this is Stuart. This was great. I think it was very interesting that you say the noise, especially with the increasing neurodivergent kids, really it's like a factor that most people don't think about, but it's so common that we see it every day. That's like it's like in your face, but it's like blind. So I think that's a really valid point because these areas, there are lots of kids and kids are going to play and scream and cry, and it really can affect the other kids that have those tendencies or for lack of a better word. So thank you for highlighting that because it's something I never would have thought of. And I don't think most safe rooms. I don't think people that do this planning think of that, but I think it's a really important component to that. So thank you for bringing that up.
Yeah, I'll just say one thing and then turn it over to Nicole. I'll just share this story. I know this is getting recorded, but we had an evaluator from our State Department of Public Health evaluate our pediatric safe room. And all of a sudden, I saw him bolt out of the room, and I was like, "Are you okay?" And he was like, I can't even evaluate this. It's just the noise is so loud, I can't even like think." And so that was eye opening for that person who, who's planning, safe spaces for like shelters and things like that, that they realized that just that level of noise was really a lot. And I took a little bit because I was just like, oh, obviously you don't have kids. No, I'm just kidding. I was like, it's important for everybody to kind of know. Nicole.
Awesome. Thank you for that. But I have a couple of things to add. So at TCH, we have a family, we still called a FRC. And we have, I think on average, stood it up at least once a year in a drill for the last, basically since COVID. But even with that, someone put in the chat to really make sure you have kind of a turnover resistant plan. And absolutely, I think it was Marie said that. And that's absolutely true because even though we've stood up our entire FRC for multiple different drills, including one that was live and had 50 children come through it. Still had new people every year that were like, I've never even seen this plan. And they were in our child life or they were in our social work departments. And so with those conversations, we've now have it like part of the onboarding process for those different areas within our hospital to make sure that they're just such an integral part of the plan that it really needs to be part of kind of their onboarding. And we've developed further kind of just in time training, just in case, we haven't been able to talk to it or haven't been able to drill to it. And really as an institution, we're getting to a point where almost every drill that we do, the FRC has some level of stand up. So even if that's, a tabletop, a conversation, it's an opportunity to remind those departments they need to do training. And so it is something that, hopefully we don't have to use as frequently as we drill to it. But again, kind of like drilling to that failure and seeing where our gaps are and what we need to learn as things are changing, the institution's changing, the people are changing. And then I had something else, but I don't remember what it was. So maybe I'll remember and come back to it.
Rebecca Scherer left something in the chat. Do you want to come off mute and just explain? It's intriguing that you have a hospital school.
Yeah, hi. So I work for UNC, so we have the Children's Hospital within our greater footprint. And one of the things that we've been discussing with our pediatric doctors is what do we do for pediatric safe area for those unaccompanied minors. And on one of the levels of our building that's on the complete opposite side from our emergency department, very far away from our ICUs. And so we actually reached out to the principal and asked if that would be an option for us to maybe leverage for those children that maybe the parent is injured in the emergency department and may not be in good condition and they don't have another guardian with them. So they offered support to take those children and kind of keep them distracted with activities and things like that. So I was wondering if any other institution has leveraged something very similar to that for children of pediatrics as it relates to reunification and pediatric safe areas.
That's really interesting. I'm going to open it up, but I would just say the one thing I would say is that even within the pediatric safe area, we actually would recommend medical oversight because they, you might have gotten screened pretty quickly and then you've gone to the pediatric safe area. You need a way to figure out if something escalates and there needs to be medical care, they can be sent back to the emergency room. So I love your plan. Like, the only part I'm a little worried is like how far away it is from the emergency room. So we have tried to keep our pediatric safe areas somewhat a clear path back to the emergency room, just to kind of think about. But others have used schools. I think that would be very interesting. Anna, would you like to weigh in?
Yeah, I mean, we actually haven't asked the schools to participate, the hospital school staff to participate, but they're actually teachers who are with the Palo Alto Unified School District. And so that would actually be a natural liaison to maybe get some resources and student directories to help with reunification. And so I'm so glad that you brought this up because I didn't even think about it until just now when you brought it up. And so I think this will be a branch of folks that we can actually reach out to really understand like how we can partner with the school district, the area school district, and then our school teachers also within the hospital school are used to liaising with multiple out of area school districts, and so that would be another kind of natural soft connect with other people. So thank you for bringing this up, Rebecca. I have so many thoughts right now just whirling in my head.
Yeah, I think that's a great comment about the condition of the children and the medical direction and making sure that there's some kind of medical oversight continuously available in that space. And it actually came about because we were talking about minors who may be old enough to drive and bring themselves to the hospital, but they're not old enough to be their own guardian, or we just don't want them roaming around our hospital. So we actually reached out to the hospital school and they said, until there is somebody who can assume custody of the child, that they would be happy like that, because every other avenue that we explored for that, they kind of raised their hands and said, we don't have the staffing for that, we don't have the authority for that. So I think that it's just something to consider is what other resources do we have that maybe they can step in and support in that capacity.
I also have to say go UNC, though not really because I'm from NC State, but anybody from North Carolina, I love to cheer on.
I learn more about you every day, Dr. Chung. Wow.
Yeah.
I'm curious, and this goes back to some of the questions, and y'all are kind of leading into this. Is Rebecca, you had and Anna, you have the school system, you have the school in your hospital, and Marie, you said that you have partnered with your school district with the drill. Are others doing this? Have others started to reach out to school-based institutions or child care centers or any other outside of the box, not normal community members that you've reached out to?
Gabe from UMC, we've reached out to the Boy Scout troops, the local Boy Scouts troops in the city.
Nice.
Is it more to run drills or to how have you used the Boy Scouts?
So we're planning a large regional exercise. We're gonna get I'm not in the planning process, but this is just from what I heard. They're gonna grab a troop and assign them to a certain hospital to play the pediatric patients.
I think that's great. I would just say that as they do their planning, just make sure that they keep that troop together. I'll share another story. We had, this is a long time ago. This is before GPS, so it was a really long time ago. But we had a Boy Scout troop that was supposed to be sent to our hospital after they were simulating two airplanes colliding into each other. And what happened is the Boy Scouts were first not going to be like on the plane. They were just going to be at the site, and then they were going to be they were all going to be sent to us. But then during the actual implementation of the drill, they got mixed in with the general crowd, and then 4 Boy Scouts were peeled off and sent in an ambulance to our place, and then a parent who was with one of the chaperones jumped into that, and then we couldn't find the rest of the Boy Scouts because they were put on a bus, and um, Boston has the worst roads, and you can imagine before GPS, but like they couldn't find our hospital. So all during this drill, they were like, "Where are the Boy Scouts? We can't find the Boy Scouts," and there was no way to do two-way communication. This is a long time ago, but so just to make sure that if there are Boy Scouts there to just or like children there, that there's extra safety measures to think about how to keep them together or make sure they don't get lost.
Rita, it's Michelle. When we were testing our reunification, we found out the schools already have plans in place with like lists of students and everything that we weren't aware of. So they collaborated very well with us.
No, totally. I think that's one thing that as you get more robust in your plan is actually also to talk to schools and community partners, because you want to know how the information you have is fed up. Like, is it through your DPH? Some people use American Red Cross in your communities. Like, where is that central source of information? Like at the community reunification site or a community assistance site, and how to make sure that information is safeguarded.
I want to start transitioning, and that was a great conversation, and I always dislike interrupting the conversation because I learned so much, and just all these little tidbits and tips I think are great to be shared. But I know you have to get back and get to your next focus area session and your next meeting and your next task. I want to quickly go back to the discussion though. If we did not talk about this, please be thinking about these. How are you going to sustain the work that you've done within your facility that you've already started with DRC? Like we've heard, it's not just we drilled, we're done. We did DRC, we're done, we're ready. It's going to be a continuous process improvement, right? And we can't stop. So how are you going to sustain this? Especially as Dr. Lazon said, plan for turnover. That's going to be the biggest thing. If you are your champion for this work in your hospital, what happens if you win a villa in Italy and you get whisked away? Who is going to take your place? Who is going to continue this work? If someone, where is it going to live? Like, where's the work going to live? So you have to leave tomorrow for this villa or you're going to lose it. Is somebody ready to take over? And do they know where the materials are that you've collected that has everything in place? So think about the who, what, when, where, and why they're doing it when you're thinking about sustainability. Think about what barriers you're going to face, because if we think about the barriers ahead of time, we can usually overcome them or figure out ways to overcome them. And we had that great discussion about who your partners are and who is missing and how to get that. So just things to keep in mind as we move forward. So, few last minute updates. You should have in your inbox somewhere, all team members received the DRC Drill 1 data collection survey. If you completed that Drill 1 survey, you should have received the link to a Drill 2 survey. So you did your first drill and then a follow-up drill. And so those data collection surveys allows you to tell us what you've done, and also so that we can see what's being done in DRC as we move forward and plan the next one. Unfortunately, today is the last focus area session for Surge for now, but we have 2 more full DRC collaborative sessions for all the 4 focus areas to come together. So we have those on May 5th and June 2nd. We will be hearing from a lot of the DRC teams. They're going to be talking about their projects, their barriers, their successes, what they've implemented, what they haven't had a chance to implement, and then how they're going to sustain their work. So you've got the session link there. So we'll see you the next 2 months there. If you were here before DRC, you were a part of the Disaster Networking Collaborative, and you went through those 10 sessions with us when we talked about C-suite buy-in. We talked about the medical director and the emergency manager role in the hospital and how important that is. And we talked about engagement in the emergency management landscape. If you are not a part of DNC, or if you want to review those, we have created an on-demand training for the Pediatric Preparedness Playback Series, and we've taken those 10 sessions from DNC and put them into a learning module, and you can get, excuse me, and you can get CEs or CMEs for that. If you're not looking for education credits, you can also get a printable completion certificate. Okay. Many of you, so we split this up in a phased rollout, but we've been talking about, since the beginning of DRC, we've been talking about the PPN portal and the DRC dashboard so that you can track and follow your progress. So this is a screenshot of the actual dashboard, but in here you can actually follow the tasks that we've asked you to do, what you've declared that in the various surveys of your hospital, and then you can compare that to DRC on the right as an aggregate. We do that also for the tabletop exercises, the drills, and then you can look at your hospital's session attendance as well. And so these are nice to be able to follow and use for quality improvement purposes, but they're also information that you can take to your leadership and say, we participated in this national collaborative, and this is some of the work that we've done. You should have gotten an email that tells you about that. If not, let me know. But there's also, we did this in a phased rollout so that half the people, half of DRC got the email last week, and half will get it next week. So if you haven't gotten it, don't worry too much. You'll probably get it next week, but be on the lookout for that, please. With this being the last focus area session, we want you to have this information to be able to stay informed, to be able to stay with us. There are several different areas. So we've got the social media. We've got our PPN website that tells you all things PPN and all things that are happening in PPN. That's a great first go-to source. We also have the PPN education website, and that has PPN Resource Central, where any resources you need, you can go there. It has our PPN Learn, where you can keep in touch and go through different modules. Our DRC website, I am hoping you are familiar with the DRC website by now, but it's got all things DRC, DRC resources. And if all else fails, that email is going to be monitored. Our DNC PPN at austin.utexas.edu, that will continue to be monitored. So feel free to email us anytime. You also have hub sites, affiliate hubs, and key partners across the country that are eager to help you. The one thing about this work in disaster management and PPN is, for me, getting involved and learning, getting to know people from EMSC, the COEs, everybody wants to help. Everybody wants to make this work throughout the country, not just in their one little hospital, not just in one their region, but everybody wants to help across the country. So reach out. If you need contact information, let us know. After June, we are looking forward to the next QI collaborative in PPN. We want to continue this work and continue because, like we said, it's not a one and done. We've got to keep going. We've got to keep the sustainability, and that means continuous quality improvement. But in between the next quality improvement collaborative and June 2nd and the next quality improvement collaborative, we're going to have a community of practice. This is going to allow you to stay connected, share progress, tackle any new challenges, and really just keep the momentum going for that sustainability. We're looking at August, October, and January, but there will be more to come on that. So definitely in that May and June session, we will have more information. And here we come to the end. If you will, please complete the session evaluation. Let us know how we did. Let us know if you need anything, whether it be something we can do better, something that, just anything, just let us know. As you can see, I'm putting things in the chat and talking at the same time, knowing that I've ran out of time, so. Okay. If you are seeking continuing education credits, the code is YUHDAP. And with that, I will say thank you. Thank you for sticking with us. Thank you for all the work that you do for our kids. And just thank you for taking care of the hospital and preparing. Liz, would you like to say anything? Or any of the speakers?
No, it's been a pleasure getting to work with you all, and we truly hope that this has been helpful. It's been illuminating for us, and we look forward to continuing on this path.